And are we going to record so that people who can't make it can join? I'll just wait. You press the record.
Yes, Tony, I'm recording.
Okay, let's go to the next slide then. So where are we at? We now have 36 sites open to recruitment, and recruitment is going well, and it's generally nice and stable. We have over 600 patients randomized into the trial overall. And just to update you, we are in conversation with the NIHR as the funder about changing our overall sample size. Things haven't been finalized. We've had a preliminary discussion with them, and because of our new primary outcome measuring not just survival but that recovery over time, we have a lot more power. And put it out tentatively, we're going to be looking to recruit about 1,300 patients is likely to be the right number that gives us enough power to answer the question. So we're nearly halfway there. We have therefore extended the recruitment date on CPMS for those people who that's important to them. We've extended it till the end of this year, and we have a request in, as I mentioned, with the NIHR to extend that funding through so that we can at least continue recruiting probably into the summer of 2027. So we've got a year and a half, year and a quarter left of recruitment, we think. We're recruiting about 40 patients a month. Next slide, please. And so this is, there's going to be a DMEC meeting coming up in a couple of weeks. And so the stats team have provided what they call a closed report. So the DMEC get to see the data broken down by treatment groups, but we just get to see it all grouped together. So the overall data, and I thought it might be just worthwhile sharing that information about who's in the trial. So we've got the diagnostic and fluid trial is the column on the left. The middle column is those sicker patients in that subset in the GMCSF part of the trial. But I'll concentrate on just showing you overall. And I would say they are what we expected to recruit in all sepsis trials. They're generally around the mid-60s is the average age. There are always more men than women. I think that reflects that there more men seem to get sepsis come into ICU rather than anything about selecting who comes into the research studies. They're moderately unwell, a median Apache of 18. Remembering this is all comers with sepsis at the time of admission to the ICU. So it's not sky high, but obviously they are a sick group of patients. And I think importantly, we are recruiting a diverse group of ethnicities into the trial, reflecting sort of UKE population. So I think we're doing a good job of who we're recruiting. Next slide. And as far as illness severity, you can see 80% of the patients on vasopressors at screening. It's obviously slightly higher in the GMCSF than those sicker patients. Just under 70% are receiving respiratory support, and that, of course, is higher in the GMCSF, whereas one of the inclusion criteria is the patient ventilated, or do they have the 2 organ supports for the GMCSF? So again, what we would expect, that respiratory support is about 70% is invasive mechanical ventilation, but you can see high flow nasal oxygen is used quite frequently nowadays in ICU. Importantly, the patients have probably been adequately fluid resuscitated at the time of inclusion into the trial. The median is 3 liters of fluid. So again, just that when people are always concerned about how much fluid they give, we have given them that initial fluid that they need in resuscitation. And obviously some patients are dialyzed at the time of inclusion. That goes up in GMCSF where there's a longer period between admission and inclusion. So that's the baseline characteristics. I think that's what we would expect it to be recruiting into the trial. Next slide, please. So just now a bit about how the sort of protocol adherence. So this is for the diagnostic part of the trial, where remember we're supposed to do, if you get the intervention, the procalcitonin tests on day 1 and day 2, and the PCR tests. You can see, first of all, the procalcitonin tests, 84% are getting it exactly as described in the protocol, those 2 tests. if you break it down, on the first day it's 93%, the second day it's 88%. And nearly 90% are getting that second test. It may just not be done exactly timelines. I would say this is okay. It is a large pragmatic trial. We understand things are not always easy to do exactly as timelines, but I would urge you to try and really stick to those timelines of doing it on the day one and then that next day, just so that we obviously have good protocol compliance. So it would be nice to get it into the combined figure into the 90% if we could. Next slide. As for getting the PCR result back, obviously, when we first planned this trial, we were hoping that we were going to use a point of care test, but for all the reasons around issues of supply of such diagnostics, we're sending it centrally. So inevitably, there is a delay in getting the sample to the lab. There were a number of teething problems early on in the trial. As you could see, sometimes the sort of minimum and maximum there. Some samples did get lost. Occasionally that does happen, but you can see the median and the mean are both around about 2 days. So we're getting results back in 48 hours. So not massively quicker than blood cultures, but we are getting them back in around the same timeline. And importantly, if we go to the next slide, I think what the PCR is showing us is actually, if you look at how many are getting a positive result, that's over 2/3 of the patients. So way more than blood cultures would ever detect. So it is a more sensitive test. So we're getting 67% positive PCR result. Similarly, if you think about the negative, which is the negative PCR and the negative procalcitonins, that's another 12%. So we're getting information sort of in 80% of our patients. They're either got a microbiology result, or actually we're pretty confident they don't have an infection. So I think that's useful information. And we don't know what effect that has on, obviously, clinical outcomes. That's what the trial will show us. But it would seem that information is probably being used by clinicians. As you see, nearly 60% of the time, there is an antibiotic change that's happening in that 24 hours after you get the result. So hopefully, again, what you're supposed to do is take that PCR result, discuss it in your normal processes with microbiology colleagues and so on, and then change your antibiotics if you feel you need to. That could be changing them to cover a specific organism, broadening them, or even narrowing down. If you know what the organism is and it's likely to be sensitive, then you can narrow your antibiotics down. And of course, if both tests are negative, the procalcitonin and the PCR, unless there is clear objective criteria for infection, the idea is to stop. You see, that's a few patients, only 32. But again, in 65%, no, or even nearly 66%, let's say 2/3 of the time, you are stopping the antibiotics, which is great. Again, we were hoping it would be nearer 80%. So just try and remember that. If there's no objective sign of an infection and the diagnostics are negative, then stop the antibiotics. They will have been treated for a day or 2 days at least. And if the markers are down, they probably don't have a serious infection. So stop the antibiotics. Next slide. This is simply to show with the GM-CSF, obviously it's the double-blind part of the trial. We don't know what people are getting, but just to point out that 80% of the patients are getting at least 50% of the 8-day course, and 71% are getting 3/4 of that. Obviously, some patients don't get a full 8 days because they die before the 8 days. And some people do get better and have gone to the wards. The protocol allows it to be given on the ward, but I fully understand that that's not turning out to be possible. We didn't think it would be, but we wanted to encourage it. If you can get it on the wards, do. But I certainly understand the issues of keeping IMP in multiple places in the hospital and getting it administered on the ward. So I'm not too worried about that if the patient's got better. But again, the drug is being given. There is an experiment going on. That which is what is important. Next slide, please. And then this is the slide I want to really bring attention to. So this is the one area where not so happy that we're doing exactly as the protocol said, shall we say. So this is comparing in the fluid intervention, the conservative fluid with deresuscitation compared to the control group. You could see overall, if we take the column on the right, the fluid balance, that this is at day 3, we're at 675 ml difference. So the more positive in the control group, which is what we would expect. We were hoping to see, we'd set ourselves a standard of seeing at least 750 mils. We were at that much previously, so we're a bit under. And if you look at where that is it they're getting less fluid coming in the conservative fluid? I think that's the column on the left, so the 723 mils. So it's positive in the control group, so less in the conservative group. You're giving less fluid, great. But then when we compare the output, this is the group again that should be getting deresuscitation. There essentially is no difference between the two. It's slightly in favor, actually just 30 mils, which is nothing, essentially, I would say. They're the same in both groups. So it would seem that maybe the deresuscitation is not happening. And that's what I wanted to bring attention to. So if we go to the next slide about how the intervention, just to remind you how it works. So as we talked about, patients get randomized. They should have had early correction of hypovolemia. You saw they're on average getting 3 liters at the time of inclusion into the trial. If they're then randomized to the conservative fluid management, then the idea is those groups stop the IV maintenance if they were on maintenance, try and make the drugs up in the smallest volumes possible, and avoid giving boluses unless there are overt signs of hypovolemia. And so those are described as that skin mottling that's larger than the area of a kneecap. If you're struggling to maintain the blood pressure, you just can't maintain it without going up on the vasopressors all the time, except they may need fluid at that time. If the lactate is above 3, that you can give a fluid bolus. And on day 1, if they're oliguric, less than 1/4 ml per kilo per hour, then again, this in those early stages of that fluid resuscitation, then you can consider giving a 250 ml bolus. If it hasn't improved things, you can keep on giving the bolus until you've given a liter, and make sure you've assessed then if you've given that liter and it's not making any difference, it's not improving things, make an assessment, actually, is this hypovolemia or not? And if it's not hypovolemia, it may be some other problem, and don't just keep pouring fluid in blindly. But hopefully that sort of fluid bolus will have corrected things. Again, it may change and you can come back and reassess. And also just to remind you, it's fine if patients need blood transfusions or if they're losing fluid in drains, for instance, we accept that they will need those replaced as well. So you can replace those. Next slide. But then on day 2, what we want you to do is assess the patients and work out if they're cardiovascularly stable and if they're fluid overloaded. So we define cardiovascularly stable as they're on a relatively low dose of noradrenaline, less than 0.2, so a sort of medium lowish dose, and if it's not increasing. And then assess if they're fluid overloaded. So have they got a positive fluid balance more than 3 liters? Have they got pulmonary edema or peripheral edema or in more than 2 sites? If they're not cardiovascularly stable or they're not hypovolemic, then you just carry on with the conservative fluid management. So just carry on. If they show signs of becoming hypovolemic, then just as you could give the fluid balances if they're therefore not cardiovascularly stable. If, however, and I think the majority of patients, the shock is generally resolving at this stage, they become cardiovascularly stable, and if they're fluid overloaded, then the idea is you actually switch to the deresuscitation phase. And so that means we're aiming to get them at least a liter negative over that each day for the first to day 5. And that means giving diuretics. So it's a combination, and it is a combination that's important. Indapamide, 5 milligrams orally, and a furosemide infusion bolus followed by an infusion. And it is both of those that we want. I think, again, I've seen it from my own practice when we've had patients. We've often given the furosemide bolus, so along with the indapamide, they have a big response. And then people said, well, I won't start the infusion. Agreed, doesn't necessarily need to start straight away. But when the urine output tails off, it's important to keep that diuresis going with the furosemide infusion. So you may not start it straight away, but I think importantly, write it up on the drug chart so the nurses at the bedside are then empowered a few hours later, once the urine output drops off, to start the infusion and titrate it, or start it at a low dose and then just see what happens and titrate it up if you need to, aiming to get to that liter negative each day, and then reassess each day, so that hopefully by day 5 they're back into a neutral balance, and whatever we stop that at day 5. So I'm going to pause there. Oh, sorry, there is one more, and yes, just thanks, Ravi, for reminding me. Just that troubleshooting, if there are any, what I would call them minor complications, basically electrolyte imbalance or acid-base issues. If the patient becomes alkalotic with the diuretics, then the advice is to add acetazolamide. Similarly, if they become hypernatremic, and then simply adding some NG water or 5% dextrose, whatever you usually use in your ICU. We're big fans of using NG water, so that's what we would do to correct that sodium, and you could increase your thiazide dose. So let's, Ravi, can we take the slides down and just have a little pause? And if anybody wants to ask any questions, either about the baseline characteristics, protocol adherence, but particularly the fluid intervention, I would be keen to hear if anybody's struggling with the fluid. And so, Sarah.
Hello, thank you. Yeah, I just wanted to bring up a couple of things that we've been discussing in Imperial with the whole team. So the first thing will be that when we identify that the patient has signs of overload, and we ask the clinicians to prescribe the 3 medications, the indapamide, the furosemide boluses, and the infusion, they are not that keen to prescribe them all. So sometimes what happens is that we can give the indapamide and the furosemide bolus. Patients, depending on the patient, gets really negative, and they are not keen to prescribe the furosemide infusion, especially for, well, basically avoid any issues over the night. So they are aware that we need to achieve -1 liter negative, and normally what they do is that if the patient has a massive response, they reassess on nighttime, and they might give perhaps a little bit more of furosemide as a bolus, and then we normally achieve the -1 liter. But they are not really keen to prescribe all the time the 3 medications, and that's been an issue since we raised this before, and I think we were discussing that this is a protocol deviation. So I just wanted to see what's your insight from that.
Yeah, I mean, I worry that, what happens at nighttime is often a little bit random, I would suggest, and therefore having, I think it's unlikely that teams will write up a furosemide infusion overnight. So that's why I just want to encourage it. I mean, if they get to the -liter, that's okay. I mean, that is what the goal is. But my concern is that it won't happen, and the evidence would suggest, obviously, I know that's everybody's data, it's not just the Imperial sites, but we aren't achieving that negative balance, is what the data is showing us. So I would encourage them to write it up. As I said, I don't think they need to give it. You might want to wait, till a bit later in the day just to see, but I would encourage that. John, I mean, you ran a pilot of this in your own site and have recruited, looked into a lot. Any comments you might have about how best to manage it?
Yeah, it's fascinating, actually. I think psychology around this is really interesting. So we don't worry at all about giving lots of fluid. But as soon as it starts to come out again, we get very anxious, and I don't really know why. I mean, the evidence for harm from giving fluid is quite strong. The evidence for harm from removing it is essentially non-existent. This is a really safe thing to do. So you should probably be worrying more about the the endless fluid boluses that the SHOs are giving overnight every time the heart rate goes up or whatever. In terms of safety, there's just there isn't really there's no evidence of a problem here. I can see why people are worried, though. It does make sense. My suggestion would be that I think what happens is that people give the initial bolus, there's a bit of response. People think, oh, we'll wait and see. Several hours pass, the urine output dries up. People start to get their antibiotics and other drugs, and that negative fluid balance is then lost by the morning. So I think it is really important that we just prescribe all three. It's called furosemide. Other name is Lasix. There's a reason. It lasts 6 hours ish. So if you want to be smart about it, you can write the infusion up for 4 hours later or 6 hours later, and then it'll continue the diuresis once the initial bolus has worn off, and that might be a compromise that works for people. So yeah, maybe delayed prescription. Would that work?
Sorry, John, can I ask you? So my concern will be that the protocol deviation is coming from not prescribing the medication or not giving the medication, because this is the thing. Even if we encourage to prescribe the three of them, but then we ended not using them, perhaps because we ended not needing it at the end of the day. Is this a protocol deviation to prescribe it but not give it? That's probably more my question.
I can't remember exactly how we phrased it in the protocol, but I think it's not giving it. I think.
Okay.
Now, that doesn't matter an awful lot if we're still achieving a negative fluid balance. So, what
because
matters is
it does
what we do.
It does depend on the patient, and some patients have a lot of response from just one bolus of furosemide, or even with the indapamide together, and then we manage to get negative the next day, or we might need to use the furosemide infusion, but the clinicians are not that keen to do it all together if it makes sense, and especially if we are on target. So that's the difficulty.
So sorry, I mean the deviation is not getting to the liter negative, I would say. So if they should have been getting to the liter negative and it was written up and they didn't get it, then that is a protocol deviation. If there's then a clear reason why they didn't want to get their liter negative, then okay, they can give that reason in the deviation why they didn't do it. And obviously patient safety trumps the research protocol. I would just go back to, though, John's point. What we need to get across to treating clinicians is, like, if everybody makes their own judgment, we won't have the experiment of comparing the two different arms. In the control group, they can make their own judgment. We don't prohibit diuretics, and they can give it if they felt they would normally give the diuretics. But the whole point of the trial and following the protocol is you have to give it according to the protocol, and only if there's a safety issue, not just, I don't like to give it, I'm a little bit out of my comfort zone because it's new to me. And I think we need to remind them that actually the European Society has actually suggested that people do this, but says there's very little evidence for it. So we're saying we need to generate that evidence, the high quality evidence, and it'll only be high quality if we get a separation between the groups. And to remind them that the data monitoring committee will be looking at this as we go on. If there was signal for harm, there has been no signal for harm in any of the previous trials. We will spot it. So I know it's really tricky, and for you guys who are communicating this, obviously it's my own site, so I need to come and have a word with my colleagues and remind them as well. But I just want to sort of empower all of you to speak to your clinical colleagues and say, this is coming from the site investigators and so on. So just to try and help it. I get why it's difficult when you're a bedside clinician and not intimately involved in all aspects of the trial protocol, but we want them to follow the trial protocol. John.
Yeah, I mean, I think this is one where this does impinge really heavily on what clinicians do and their judgment, and so probably feel people, if we're honest, probably feel a little bit threatened, a little bit uncomfortable around that. But hey, we're doing this because we think it will improve patient outcomes, and there's evidence to suggest it might, and there's guidelines to support it. This isn't some crazy, there are other trials which are really pushing the envelope in terms of what we do. This is not. This is a version of usual care. It's not the version that everybody uses. That's okay. That's why we're doing a trial. And I think those conversations are difficult. I think they're probably easier if you're the site PI, and do please, I don't know who's who online, but if you're one of the research coordinators and you're struggling to make that impact, then really do bring in your site PIs to help, because I think they'll maybe be able to make that case more effectively than if they're a colleague. That does help, definitely help. Yeah. So look, but the important thing is this is not a suggestion. This is a protocol. We do ask you to give all three and achieve at least a liter. So if you hit a liter, that doesn't mean you have to stop. You can keep going if everything's fine. That's good. You can also down titrate. You can start the infusion at a different rate. So if you're not ecstatic about starting it at 5 milligrams an hour, you can down titrate pretty rapidly if you're getting a really good diuresis. So there's freedom there within the limits of the protocol, but we do ask you to work with the protocol. Yeah.
And just to add to that, it's interesting. We've had some sites saying they can't take part because, obviously, as you're saying, they don't like giving the diuretics. Other sites have said, we can't take part because we already give diuretics to everybody and do deresuscitation. So, it shows you the clinical equipoise. It means everybody has not everybody. Lots of people have fixed views, and you can't all be right. So that's why we need to randomize. But sorry, did you have a second point you wanted to raise?
Yes, sorry. Well, it's kind of the same thing, really. The other challenge is that whenever patient fits the criteria, and we approach consultants, they not keen to start the resuscitation. So yeah, it's not always possible to convince them to follow the protocol.
Yeah.
It doesn't happen that often, but it happens sometimes.
Yeah, I mean, it's all part of the same thing. I think that's it. And just to remind, that's why I put it at the beginning, because I know we've had some of those discussions locally. Sorry, I know with people losing fluid in drain. So if they've had abdominal sepsis, had surgery, they've got a lot of drain fluid coming out, they can still replace that drain fluid. No one should be hypovolemic. So if they're losing fluid because they've got an open abdomen, and they've left it open and they'll be losing fluid, that's okay. We don't want nobody should be hypovolemic. But what we want to avoid is so much, as John said, it's that particularly middle of the night when some minor thing has happened and the instinct is, let's give 250, even 500 of fluid because the urine output's dipped, the heart rate's gone up. There was a single blood pressure reading that was a bit low, to avoid that. So, but just ensure people that there should be no hypovolemia, so that that there is safety.
Thank you.
Any other questions from any other sites? Anybody else before we go to just a little bit about data entry? Is it Zaka? Is that him? You're on mute at the moment. We can't hear you. So the question from Ashley about giving the oral drugs if the patient has an ileus, I would suggest you do still give them. Like sometimes things are absorbed anyway. So I would just give it as we do. That's the process I take for most of our oral meds. They still get the IV diuretics as planned. Zoc, I don't know if you're still on mute. I don't know if you can unmute and ask a question. If you're, I don't know if there's some technical issue. If you want to, yeah, I can't get microphone to work. How do you balance patients requiring with the fruit? So if they're having if you want to give them renal replacement therapy, they get renal replacement therapy. You don't need to give the diuretics, and then you just take the fluid off and the balance. So you would aim for that liter negative in the 24 hours. Just use the renal replacement therapy. You don't have to give the diuretics. Because, most patients stop peeing once they're on renal replacement therapy anyway. Hopefully that's answered. Great. Okay. Any other questions? Okay, thanks, John, for joining. I know you had to go, and yeah, please do contact John either directly or via the team, and we'll pass them on. We'll find him. Cheers, John. Have a good day. Ravi, do you want to present the last few slides?
Sure. Okay, hopefully you can see that now. Yeah. So this is just more of a reminder, I guess, maybe some of our newer sites who've joined us about how, following on from the fluid intervention track, how the data will be entered as well. So this is just to show you from start to finish. So any patients randomized to this intervention will show up as conservative fluid therapy with deresuscitation or standard care. And then at baseline, on the baseline form, you should enter the total fluid given in the previous 24 hours prior to inclusion. So we set out what this includes, and this information is also in our ECRF completion guidelines. And then day one, this is probably where we get most of our queries. Day one begins from the time of randomization until the end of the chart day. So from day one, so as soon as they're randomized, then we're looking at total fluid input and output. And then from day 2, 3, and 4, and 5, you'll just be following your regular chart days. And then here we explain, so total fluid input on that day includes IV and enteral intake, nutrition, drug volumes, and transfusions. And then the output includes urine, renal replacement therapy, and drain outputs. And just to note that the grayed out boxes, so the cumulative fluid balance, they are auto-calculated by the database. So if they don't quite match up to the calculations that you have, you might need to go back and check that all of the days have been entered correctly so that the database will auto-calculate the totals. And then just our final few reminders. We circulated a recent amendment earlier this month where it was just a minor change to the patient-facing PIS and consent forms. So this allows for patients who may have weak handwriting to add a tick instead of their initials. So to help us implement this amendment, we just ask, if you haven't already done so, please to send your localized PIS and consent forms to our SepTiC inbox for us to review. And the 35-day deadline is 17th of March, so we're hoping to implement it to all sites by that date. And we've got quite a few sites in setup, which is quite exciting. We're not sure if maybe anybody from these sites was on the call, but if there are any issues with site setup or any queries that you have, do get in touch. We're quite keen to get everyone open and recruiting fairly soon. And then, as Tony mentioned at the beginning, this is just the same reminder that we had in our last webinar, which is there are new GCP guidelines that will be implemented from the 28th of April. So we ask that everybody completes the new GCP training by the 27th of April at the latest. So even if your current GCP training might be in date, you'd still need to complete the new training. And if you need to do a refresher at any point between now and then, it's best to just complete this on the new version. That's kind of it from us. We've got another webinar next month. We're trying to keep them all quite regular, and we'll send another calendar invite closer to the time. I'll just stop sharing in case there are any other questions for Tony or the rest of us.
Yeah. Thanks, Ravi. Yep, just to remind you, we're all having to do our GCPs. Ravi, you keep reminding me, I'm 40% through mine. So let's get everybody done. Any questions from anybody? Ashley? Hi. Oh,
Hi, Ravi. Can I ask? I have a question about data collection timeline. So in the ECRF guideline, it says like the microbiology results, the timeline should be day 1 post randomization. Is that correct, or like or should we look at any microbiology results which came through like up till day 28?
Actually, just to check, is this the microbiology page or is it the blood cultures that we have?
It's a microbiology page I'm talking about, because in the ECRF it says like it has to be done on baseline or on day 1 post randomization. But is that right, or whether we should put any positive results up till day 28, which needed antibiotics?
no.
Where we needed antibiotics to stop and restart.
It's my understanding this page is just asking about that whole 28-day period.
Yeah, maybe then we need to change that in the ECRF guidelines.
Can I just check, Ravi? I haven't got the ECRF in front of me. I thought we collecting the microbiology at baseline is to understand what the infection was at baseline, and then I thought it was only over time are we asking about blood cultures. We collect antibiotics for 28 days, and then if there were positive blood cultures. But don't worry, it's obviously a while since we designed the CRF, and I haven't looked at it recently. But if you collect all microbiology for 28 days, that's a lot of work. And I deliberately want to keep this simple and easy for people. So it will take me a while to log in.
Maybe, sorry, just to clarify, Ashley, is this the question that's after randomization, has the patient experienced another episode of infection?
Yeah, where we needed to restart antibiotics or something. When we recruit patient within 24 hours of coming to ITU. So I don't know, the pop-up question is not very relevant, where they're asking where patient needed to stop antibiotics and restart because of a new infection.
So this is, Tony, just to explain, this is a question on a separate form, so it's separate to the blood, where the blood cultures were taken. It's asking, after randomization, has the patient experienced another episode of infection? So defined as a new course of antibiotics, including antifungal therapy 48 hours after stopping the previous antibiotics.
Do you want to
Yeah, this is the question.
your, sorry, do you want to share your screen, Ravi, if you've got it there?
Yeah.
Would that be helpful for us all to look at? Just to make sure Ashley's on, it's the right one that Ashley wants to.
This is the right one I'm asking about. So my question is the timeline for whether this should be completed at day 1 or this should be completed at at day 28.
Maybe I can step in. I've got the ECRF manual open. So on page 44, yeah, it says, yeah, it can be completed after the 28 days. Once the 28 days is completed, this can be completed retrospectively.
All right, thank you. That's all. I just needed to cross check.
I think if there's maybe actually if you could email us if there's any discrepancy. I think you mentioned that. Don't know if there's something else, but
Yeah, I don't think so. Like, we have updated that, like, section 4 date and date, but I couldn't really see that in the ECRF. In ECRF, I could only see a timeline for day 1. So that's why I kind of cross-checked it just to avoid confusion. Yeah, sorry.
that's okay.
Can I check one more thing? Like, I know like the study is getting extended. My last patient, when we included him, we really didn't know his baseline capacity. He had background of learning difficulty and everything. Some of the studies do like proxy follow-ups. I don't know whether it's something good. We couldn't consent him after when he regained his. When he's alert, we tried to assess him, but I don't think he can complete the follow-up. So like some studies like shorter, they do proxy follow-up, like, this patient specifically came from a nursing home. So like, somebody who look after the patient can do the follow-up for the patient. It's just something the study would like to look at.
Yeah, I'm sure we have it in our guidelines, but our only follow-up that's conducted with the patient at the moment is the EQ5D, and that can be done by the patient or it can be done by a proxy as well.
Oh, I didn't know that proxy can do it because, yeah, I'll cross-check the protocol. So
That's okay. I think sometimes with our guidelines, it might be easier to just search through them and then see on some of the other pages. Just having a quick look. Yeah.
all right, thank you. That's all.
Any other questions, comments from anybody? I'm interested. The DREAM research team. What does DREAM stand for?
That's the Nottingham team, isn't it? Where are they? Anyone speak? Anyone?
What makes you the dream team? You might be. You usually do very well in all the trials. So I just wonder what the letter stood for. It's a good acronym.
We did recruit a lot of patients in December as well. I think about 6.
I know they're gone quiet there. Okay. If there's nothing else, thank you all for participation. Good luck to those who are screening today. Hope that works. Claire, did you have a question or a comment?
I was just going to say that we could make the fluid interventions slides available, but perhaps in a diagram format for printouts as well. So if it helps understand the protocol.
If anybody's got any ideas of things that will help, and if we can help produce them for you, let us know, and we're happy to do that. Do reach out if you've got ideas. Similarly, sharing learning between any of you, if those who meet in little networks and so on, that shared learning is always helpful, and we'll think about that going forward with these webinars. Again, if any of you want to present and talk about what's going on in your site, both good and bad, share what's going well. We're very happy to do that. And it's simply if you just want to ask people for their thoughts or guidance or how they if something you're struggling with, ask other sites how they manage it. That sort of shared learning is what we want to do. So let us know. But I really appreciate it. The recruitment is, nice and steady now, and we'll let you know when we get the updated news from NHR about the extension and the exact dates and the like. Hopefully it won't be too long now. Thanks, everybody. Bye-bye.
Thank you. Bye bye, everybody.
So bye.
Thank you.
Bye.
Thank you. Bye.